Good afternoon, everyone. Good afternoon. Welcome to Grand Rounds. My name is Tom Feldman. I'm the chair of Grand Rounds. It's a real pleasure to see you all here today. I thought that this might be a crowd pleaser, standing room only. So if you're just coming in, there are a few spaces at the front. You'll be sat quite close to the front, but you can squish in there if you want. I'm sure Sarah will make some space. There she goes. She doesn't bite, unless on request. So we're going to talk about novel coronavirus, and we've got a team of folk who are here to do that, who've been sort of press-ganged into doing it at very short notice. And the Chinese may have built a hospital for 1,000 patients over a weekend, but they've written this talk over their weekend. Before we get started, though, you'll see a poster up here. Nicola Henderson's here. She's going to talk to you over here in these microphones about the upcoming Tayside Doctors' Winter Ball.
Thank you, Tom. We were all talking a few weeks before Christmas that we rarely get a chance to go out and get dressed up and socialise together as a hospital. And myself and Carol Gray worked in the West Coast for a while, where that was very much part of the hospital culture, that there was a doctor's ball every year, and it was very well attended, great fun, and very good for building relationships and morale in the hospital. So we have booked the Apex for Saturday the 7th of November, and would like to encourage everybody to either buy a table and come as a department, or to buy individual tickets, and we can try and sit you with people you like. But it's a Tayside Doctors' Ball. It's open to Perth, it's open to Ninewells, Stracathro, wherever you work. If you're a doctor in NHS Tayside, come along and socialise with your colleagues. And we've booked this wonderful band called Jim Jam, who do a fantastic mix of Ceilidh and of covers and dancing, so there'll be half disco, half Ceilidh. We've already got interest from about 100 people who are keen to attend, so please, if you can spare the money for a ticket on a Saturday night, it would be really nice to see you there. And you can contact Helen Lidicott, myself. We're going to set up a Facebook page. Matthew Checketts and Carol are anaesthetists, but we'll have a Facebook page soon and a dedicated email, so please speak to us if you're interested. Thank you.
Thanks very much. I'm just trying to direct traffic. Isla, there's a seat at the front if you're looking for somewhere. Okay, so the record attendance at Grand Rounds was about 5 years ago when Morgan Evans talked about Ebola, right? And it looks like we've broken that record by talking about the next catastrophic plague. It's very interesting that these sort of zeitgeist moments of infectious diseases draw such a crowd. Perhaps you're all just panicking that you're going to get coronavirus, but I think there is a genuine interest in this sort of stuff, and it slices through everybody, doesn't it? Everybody's speciality. We all may well be affected by this virus. So I'm told by Boosie, who's elegantly sidestepped having to do any of this presentation, despite me being the first point of contact. She tells me that this is some of it's quite operational, so it's going to be telling you about what it is you actually will do if we reach Virus Con 1. But I think we've got some background information on the virus, etc. It's a team effort. Nick and Catherine and Ali and Neil as well, forgot his name, terrible, Neil, are all going to give a little bit of a talk. So I'll sit up waffling and we'll get on. Thanks very much, Nick.
Right, so, as was kind of alluded to by Thomas, the gauntlet was thrown down. We said, well, if the Chinese can build a 1,000-bedded isolation unit in 8 days, surely we can cobble together half a dozen slides and talk about the evolving threat of this new novel coronavirus that has sprung up in China. So we rose to the challenge, and here we are. That is the nearly completed facility just outside Wuhan, isolation unit built to house over 1,000 patients, so basically the same size as Ninewells. Absolutely mental. So what will we speak about today? Very briefly, I'm going to talk a bit about the history of epidemics, the previously described novel coronaviruses. So if some of you are old enough to remember SARS and MERS, and I know certainly a reasonable number of faces in the audience will, I'll touch upon them, and then I will discuss the more recent 2019 novel coronavirus. I will then pass on to Ali, Catherine and Neil, and I will allow them to discuss the local protocols for the assessment, an initial investigation of patients and testing, and there will be some discussion around personal protective equipment, including some audience participation. We're not expecting any of you to get up and get dressed, but some of our team members may well put on different bits of their personal protective equipment to show you. So, definitions, epidemic and pandemic, so both from Greek, epidemic meaning upon the people, and pandemic meaning all the people. And again, slight differences in terms of the actual distribution of where the population is affected. In epidemics, generally, it is a large proportion of the local population within a short space of time, whereas a pandemic is something that is worldwide, multi-regional, and hence the use of the word pan for all. And a historical perspective about epidemics. So clearly, humans, since before records began, we know that in the Bronze Age even, our ancestors and throughout time have faced various infective pathogens, some of which have wiped out vast numbers of our ancestors, and these have come and gone. And interestingly, when you look back at the historical information about these epidemics or outbreaks, some of them are attributed to specific diseases, and a lot of that attribution is due to historical accounts at the time. And we actually know through modern genomic sequencing that there are some outbreaks or epidemics that were wrongly apportioned to certain pathogens. Particularly, for example, one of the outbreaks of the Black Death, of plague, was attributed to a presumed viral illness, and it was only ascertained to be plague after genome sequencing in some of our ancestors, and some of those affected at the time confirmed that they'd been infected with Yersinia pestis, the bacterium that causes plague. That's a kind of reasonably accurate pictorial representation of me doing a ward round in Ward 42, armed with a big stick to kind of bash off the fourth-year medical students who are performing to an inadequate standard. Seeing as Dilip Nathwani's left, someone's got to carry that mantle. Jokes aside, in talking about the Black Death, although it was very difficult to not get a picture in of the plague doctor. And this is a kind of if you like, a timeline of epidemics, and you can see the number of different pathogens that the human race has come across, and some on multiple occasions. And obviously, like I said, Yersinia pestis makes numerous appearances here, and there are some things that are still not 100% clear, the exact pathogen, thought to be typhus, typhoid, measles, or smallpox. Some things we're not. Again, the historical descriptions aren't quite good enough to give us an absolute, make it absolutely certain what the cause of these outbreaks were. But that gives you a good broad overview of just how tough the human race has had to make it this far, battling against these bugs. Coronaviruses. Now, I do apologise for the formatting of some of these slides. I did it in PowerPoint, and unfortunately we've only got OpenOffice here, so it's NHS standard issue. So the text is slightly smaller. Thankfully, I'm not at the back of the audience, otherwise even I'd be struggling to read that. So, coronaviruses. Corona meaning crown, and you can see in this scanning electron microscope that we've got, you can see the kind of reason why they are crown-like, the general appearance of the viruses. They're an RNA virus, and they divide into 4 families, so alpha, beta, gamma, and delta coronaviruses. And they are an exceptionally common cause of self-limiting upper respiratory tract infections in humans, so the common cold. And there are 4 main strains that are responsible for that. There are, however, a wide range of other coronaviruses that cause a whole host of often quite virulent diseases in animals, and in a range of animals. Those include both respiratory tract, gastrointestinal, neurological diseases. So there are wide-ranging manifestations of coronavirus infection in animals. And really, in the last 20 years, we've had 3 additional coronaviruses that we know can and do cause disease in humans. That's SARS-CoV, MERS-CoV, and this new 2019 novel coronavirus. The main method of transmission for coronaviruses in humans is primarily through droplet. Now, there have been debates about it being aerosolized, and that it's not been conclusively proven one way or the other, but the bulk of transmission of coronaviruses is likely via droplet. So SARS. So a few of you in the audience probably won't remember SARS. I do, because I happen to be living in the Far East when that all happened. It was initially reported in November 2002 in Guangdong province in China, and there was a big cluster of patients who presented with severe bilateral pneumonia, adult respiratory distress syndrome, with no obvious microbial etiology found. And it was interesting that the initial clusters of cases really had quite a marked biphasic kind of natural history, and that initially patients would present with respiratory symptoms like cough and breathlessness, and sometimes fever, and then things would tend to progress when they were more than a week into the illness, and they would develop lots of diarrhoea, and then a marked increase in respiratory distress, respiratory failure into the second week. And interestingly, a large cohort of the initial group of patients were workers in restaurants, handling exotic animals for culinary purposes. And that was very popular in China, and still is. And subsequently, a novel coronavirus was identified and sequenced from a group of affected patients. And testing of various other animals in light of this connection with restaurant work and handling of live animals for food purposes revealed that there were a number of very, very similar SARS-like coronaviruses in animal hosts. The closest one being a civet, so it's a small kind of cat-like animal, which is very popular in China. And raccoons were another one. These are two. This is a kind of a very good kind of radiographical natural history of severe SARS in two cases, both of whom acquired their SARS infection from the same index patient in the emergency department. So one was actually a nurse working in the emergency department. The other was a patient who was being assessed in the emergency department with gastritis, and they both acquired their SARS in the emergency department from the initial index case. But it gives a very good, accurate kind of description. You can see kind of what I was alluding to in terms of the kind of onset of more severe respiratory distress occurring in the second week. So moving through the days and into the second week, where you can see these dense kind of bilateral pulmonary infiltrates that are evident in both patients, particularly evident on day 11 there. SARS really became an international issue when a doctor who'd worked from China travelled to Hong Kong and stayed in a hotel, and a number of guests and visitors at the hotel became infected, and they therefore disseminated the infection to around the world, so some to Canada and out throughout Southeast Asia, including Vietnam, Thailand and Singapore, where there were further outbreaks. And nosocomial transmission was particularly a feature, and often because the doctors and healthcare staff looking after the patients were not aware of what they were dealing with and the risks that they were exposing themselves by seeing patients, performing invasive procedures, particularly aerosol-generating procedures like intubation, and all told, over 1,000 people had contracted SARS with almost 800 deaths. Finally, the epidemic was declared over in July 2003, and SARS has not been seen again. Interestingly, another novel coronavirus was picked up almost 10 years later, and it was initially identified in a man from in Jeddah, Saudi Arabia, who had severe pneumonia. And retrospectively, there was a thought about a cluster of severe respiratory illness which occurred in Jordan earlier that year, where there were a cluster of patients. And looking back retrospectively, testing samples from these patients revealed that they had also suffered from the same novel coronavirus. It's a beta coronavirus, very similar to SARS, but it is very closely related to coronaviruses that affect bats. Multiple animal vectors were tested for an antibody response to MERS because it was felt that bats were unlikely the main link between in terms of humans acquiring infection. And indeed, the only seropositive host identified on the Arabian Peninsula were camels. And up to 80% of camels were seropositive, and retrospectively, looking back at camels in terms of historical samples that have been obtained, certainly you can identify MERS or seropositivity to MERS in camels back into the 1990s, and in some areas even back to the 1980s in the Arabian Peninsula. So MERS has been around for a while. Exactly why it has jumped ship into humans when it did is not clear. It does have a strong predilection for men, for the elderly, and for those with comorbidities. And again, similar to SARS, gastrointestinal symptoms are common, but unlike SARS, it does not follow a kind of biphasic illness history, and it tends to be a rapid development of respiratory failure within the first week of illness, and mortality rates are higher than they are for SARS by at least threefold. So probably about a third of patients with MERS-CoV die as a result of the infection. And this is a cohort of patients that were looked after in the Middle East who all have MERS and were all in critical care facilities with MERS. And you can see there's a bilateral distribution in the majority of the X-rays, and with a strong predilection for the lower zones on the chest X-ray. Since MERS has been identified, there have been episodic outbreaks, mainly confined to the Middle East. About 2,500 cases worldwide with 850 odd deaths. And there have been several nosocomial outbreaks, but the transmission person to person appears considerably less potent than did with SARS. So it's quite difficult for MERS to be transferred person to person, and so it does not quite seem to have the same pandemic potential, if you like. Certainly there was a large outbreak in the Republic of Korea, lasting from May to July in 2015, when almost 190 patients were infected, and that was following an index case travelling from the Middle East to Korea, seeking healthcare advice from multiple healthcare facilities, and again, the suspicion of MERS being low, therefore appropriate precautions not being taken, and there was a subsequent outbreak in Korea, which was contained within a couple of months, thankfully. And that's WHO data, if you like, indicating the ongoing reporting and incidence of MERS. And again, the bulk of these cases, as you can see, are from the Middle East, bar this spike in 2015, where there was a large spike of cases due to the imported outbreak that kicked off in Korea. So, the new kid on the block, if you like, the 2019 novel coronavirus, or Wuhan novel coronavirus as it's been termed. So this was initially identified in early December when multiple cases of pneumonia with an unknown etiology were identified in Wuhan, in China. The initial patient was actually in early December. And again, thinking back to SARS, there was a common link in terms of food. Or animal sources, and that most of the initial patients had a link to a seafood market. Either they worked in the seafood market, or they lived in very, very close proximity to the seafood market. And it wasn't just selling seafood; they sell a whole bunch of stuff there: poultry, bats, snakes. There's a wide range of animals that are sold mainly for culinary purposes, and the New England Journal of Medicine was a case report where they identified a novel coronavirus from 3 patients and sequenced it, and they noticed that it's a very similar virus to a SARS-like bat coronavirus. But the actual source or animal host of the virus is not yet confirmed. That is under a lot of intense speculation. There has already been speculation about snakes being a potential intermediate source, but that's not clear yet. And these are X-rays from the first 3 cases that were reported in the New England Journal of Medicine, patients that presented in December. And these are chest X-rays taken 3 days apart from a 61-year-old man from Wuhan who developed rapidly progressive respiratory failure and subsequently succumbed to his illness. And this is again from that paper. this is a electron microscopy where the authors have performed cell virus culture, and the arrowheads rather, indicate, if you like, the actual free virus, and these are kind of virus conglomerates in cells. Clinical features of the novel coronavirus from Wuhan. The incubation period, in keeping with MERS and SARS, is at most 14 days, but is often within a week. And almost all of the cases will have at least one of fever, cough, or breathlessness. And a cohort of the first 99 patients treated in hospital in Wuhan, aggregating all of their symptoms, 90% of their patients had at least one of those symptoms. It's more common in men and those with chronic conditions, similar to the other coronaviruses, and the majority of patients will have bilateral chest X-ray infiltrates versus unilateral, so that 3/4. In contrast to SARS and MERS, diarrhea and vomiting are much less common in 2019 novel coronavirus. And about a quarter of patients developed acute lung injury or ARDS in the context of their illness, and 11% required ventilatory support, so that be it non-invasive ventilation or intubation, mechanical intubation and ECMO. This is information from ECDC on the kind of the rising number of cases, and again it's only up to the 4th of February, but again you can see the bulk of cases are within China, and the numbers are still increasing. And again, this is from the World Health Organization. This is a nice pictorial representation of the distribution of cases, and almost all states in China are affected. Tibet seems to have got off lightly. Maybe it's because the Tibetans don't like the Chinese very much, so they don't interact with them. But and you can see there's a wide range of countries that have also been affected and have a relatively small number of cases. But the Philippines is the only case outside of China to have reported a death. And that's the list. I won't dwell on that too much. So how infectious is it? It's difficult to quantify, and I think the problem is, especially when you have such limited information, you can use what's known as the R0, and that's the kind of basic reproductive number, and that is reliant on 3 factors. So the transmissibility of the virus, how often infected are coming into contact with susceptible people, and the kind of duration of infectiousness. So it's quite a complex thing to kind of model, and again, you need to bear in mind that lots of patients, lots of people are exposed to viruses but just develop subclinical illness and do not develop symptoms, and therefore tracking exactly how many people are infected is difficult. And so being able to say how many secondary cases you have following exposure. Again, some patients may have very, very minor symptoms that they put down just a cold and just forget about it, and they get better, whereas obviously the ones that are much more likely to be identified are those with severe manifestations of disease. As it stands, the current estimation for this novel coronavirus is between 1.4 and 2.4 for an R0, which is actually not as high as you would expect. It's lower than SARS. Now that's a bit thicker than I was expecting it to be. So you can just about see what it is. I blame Open Office for this. So you can see I've put down just bang in the middle of that horrible fat circle is where 2019 novel coronavirus is. SARS is actually just above it, so it's actually more infectious and has a higher mortality rate. And MERS, you can see on this side, in this graph plotting, if you like, the contagiousness along the bottom line and the lethality along the vertical axis. You get a rough idea of actually how infectious is it. I mean, versus things like measles, it's actually quite difficult to catch all of these coronaviruses. And MERS in particular, again, the figure, where MERS is plotted there on the left-hand side, indicates that actually it is very difficult to transmit MERS person to person. But obviously, the risk of death is quite high. All right. But I guess that kind of puts it in perspective. I've got a few quibbles with some of the placement of a few of these conditions, but I think it's useful as a kind of representation of where this novel coronavirus roughly fits in the big picture. Treatment. So, supportive treatment is the mainstay, and essentially patients need to be isolated, and that may be at home if they're completely well, but is often in hospital, and ensure that the appropriate personal protective equipment is worn by staff. And you should also minimise staff contact. Again, what you want to do is reduce the risk of ongoing transmission. And again, as a result, you want to avoid unnecessary procedures or investigations. So reduce the amount of people that could be exposed to body fluids or kind of air, droplets from a particular patient. Multiple strategies have been trialled in patients with SARS and MERS. So corticosteroids have often been used, particularly in the context of adult respiratory distress syndrome, and do have some benefit in that context. But other, for example, type 1 interferons, interferon alpha, have been trialled, particularly in MERS, and along with ribavirin. The evidence base for which is very, very weak, and it doesn't seem to do anything. And convalescent plasma or immunoglobulin are, again, seem like an attractive prospect. You think, well, if somebody's survived and they've got some kind of antibodies, that may help. But most patients don't have a high enough level of antibody for it to be an active therapy. Interestingly, lopinavir, which is quite an old protease inhibitor for HIV, has been trialled in both SARS and MERS, and in China they're trying to use it in this novel coronavirus. I mean, those of us who work in HIV medicine know that lopinavir is actually really bad for giving people lots of gastrointestinal upset. I'm not sure that I would want that, but I guess when your back's up against the wall, you maybe try anything. So I guess that's me. So what I will do is I'll hand over to Ali, Catherine and Neil to go through our local policy for assessment and investigation of patients with possible novel coronavirus.
Thank you.
So the plan is just to take you through the local guidelines of what you're going to do if you meet one of these patients at 3 o'clock in the morning and how we're going to manage them here in Tayside. The caveat to all of this is that it is a very fluid situation still, and the guidelines are kind of changing as quickly as we can create and update our own. Where possible, we've tried to overcome this by embedding various hyperlinks with PHE and HPS, but we will update this if things change. So for the here and now, please just follow the guidelines. So it's not just one page, as I'm sure you expect, but this is the front page. We'll go through it section by section, but that's just an overview of what you're going to get. What we want to stress in the sort of top part of text here is that these guidelines are not just for medics in AMU, they are for everybody that is triaging patients into hospital. So the earlier we identify these patients, the better. And if we identify them before they even enter the building, even better, because we can then do a better job in terms of infection prevention control, minimising onward spread. So anybody that's triaging in any department should be aware of these. So to be a possible case of Wuhan novel coronavirus, you need to fulfil both the epidemiological criteria and the clinical criteria. And we'll go through those separately. So the EPI criteria is in the 14 days prior to the onset of the illness, the patient has travelled to a high-risk country. And at the moment, that high-risk area, which was extended at the end of January, is the whole of mainland China, but excluding Hong Kong and excluding the island of Macau. Or perhaps they haven't travelled, but they've had contact with a confirmed case. And contact we're defining as someone who's living in the same household. It could be a healthcare worker who's had direct contact with the patient, with bodily fluids or with lab specimens, or anyone that's been in the same room in a healthcare setting when an aerosol generating procedure has taken place, or anybody that's just been within 2 metres of the patient for any prolonged length of time. So those are your epidemiological criteria. And the clinical criteria is a bit looser. So you've got your sick patients, so that's your severe acute respiratory infections who require admission to hospital with clinical or radiological evidence of pneumonia or an ARDS picture. And those patients are obviously already going to be in a healthcare setting. So the focus really of these guidelines is on the second set of the clinical criteria, which is the acute respiratory infection of any degree of severity, but including at least one or any combination of fever, shortness of breath, or cough. And as always, there are caveats with these things, and the caveat to that one is just be aware that you might get some atypical presentations in immunocompromised populations. And above and beyond all of that, even if you've got somebody presenting who doesn't fulfil the clinical criteria, if they've had contact with a confirmed case, health protection need to know about it, even if they're asymptomatic. So you've fulfilled the case definition. Now what to do if you've got somebody in front of you or on the phone that meets that case definition? So if they're not already in hospital, are they well enough to stay at home? And really we want the answer to this to be yes. We want to keep them at home if possible. So if it doesn't sound like they are crumbling on the end of the phone, you want some clinical details from the patient. We need a contact number from the patient, and you're going to tell them to self-isolate and stay in their house. Then you're going to hang up and you're going to ring health protection. If they do sound like they need to be admitted, in an ideal world, in hours, we're going to facilitate that to a negative pressure room in 42 and do so by ringing ID on call. If it's out of hours, if it's 3 o'clock in the morning, we still really want them on ward 42, but we're going to have to facilitate that through medical admission, so by phoning Reg B overnight, but also we need to let the lab know. They need to know to expect the specimens, we need to be contacting health protection, so you need to ring both of those groups of people. So that's for your patient that's at home or they're not in the building. If they're already in the hospital, and we're hoping they're not, the first thing you're going to do is put a fluid repellent surgical mask on the patient. You then need to ensure that any staff member that is in contact with that patient has got appropriate PPE on, and we will come back to cover exactly what that is. We need to think about where the patient is going, which team's going to look after them, and what room you're going to put them in, and there is an entirely separate document for that as well. Just to reiterate what Dr. Ray said, you want to minimise any staff contact patient where possible. And as well as that, we need to be keeping a log for contact tracing of exactly who has met that patient. So we need a log of all staff members, domestics, anyone that's been in there and had any staff-patient contact. And once you've got a mask on the patient, you've got some PPE on, and you've finally got time to breathe, you need to ring the clinical infection service. So again, it's the same numbers. In hours, you're going to phone ID on call, and out of hours, you're going to speak to the microbiologist on call. We appreciate in the clinical setting you might need extra pairs of hands to do this, so if you do, you can do that through the bleep holder. This logbook is attached to the guidelines. That's where you are going to document everybody that's been in contact with the patient. There's 2 logbooks. There's one for staff, there's one for visitors. This doesn't mean we're encouraging visitors. Visitors should only be in there if they have to be. So we're talking parents of paediatric visitors or necessary carers, not people delivering Lucozade and grapes. So assessment and diagnosis. So this is assuming you've got your patient somewhere safe. So again, minimise contact. Don't go in there unless you need to. If you're going in, you're wearing PPE. You're not sending the medical students in to practice clerkings. And ideally as well, from a nursing perspective, we want to try and minimise the use of bank or agency staff. And then in terms of what you're going to do, so examination, observations, routine investigations, those things we almost do out of habit, do them only if you need to. Do them only if it's going to change your clinical management. And particularly chest x-rays. Really, we only want you to do it if actually you've got a profoundly hypoxic patient that is perhaps going to need some sort of ventilation. They can be done. We can get the radiographer in there, but the radiographer needs to be in PPE. The machine needs to be cleaned. Doesn't mean it can't be done, it's just a faff. We want to minimise it if possible. And then we're going to take some samples. Now, all of this has been wonderfully packaged up together by Dr. Sean in the lab. And if you go onto ICE and you put in the search box for Wuhan, you get a testing set. So you don't need to remember all of these. It will tell you exactly what you need to do. Part of that is a set for us in the lab, and part of that is a set to go away to the reference lab. 2 throat swabs, 1 nasopharyngeal swab, red top swabs. Sputum if you can, but please don't start doing induced sputum on these patients. Send some blood, and if we can get it, we want urine, we want a stool sample. But if you can't get it, just send what you've got. And then you need to get your specimens to the lab. So all the samples coming from these patients should be treated as biohazard. You have to inform the lab before you send the samples up. You don't want some unfortunate biomedical scientist stumbling across these at 5 p.m. So please phone them before they're sent. Do not put them in the pod. All of your specimens are going to be double bagged, and they're all going to go in these sweetie jars with a screw top lid. And you can find those on 42 in A&E, and you can go and get them from the lab if you need them. And the same will apply if you are sending other blood tests, if you want biochemistry and things done. And at the moment, we should be getting results back within 24 hours or so. At the moment, the reference lab is PHE Colindale, and the samples are being couriered down there. But as of Monday, we should be rolling out national testing and able to get these samples done at Edinburgh or Glasgow. So it may be a little bit quicker than that. Please don't suddenly take the PPE off as soon as you've sent the samples. Keep it on until we've got a result. But that step down needs to be following a discussion with one of the infection team, because there are caveats, as always, with these patients, and there may be some that need further testing and follow-up testing. And just a note on the respiratory PCR, so your normal viral throat swabs that you're sending to the lab, these test for coronavirus, these test for the common strains of human coronavirus. So I think there'll be lots of clinical scenarios where people have had positive coronavirus on a viral throat swab over the last few weeks. Unless your patient fulfills the epidemiological criteria, they do not have Wuhan novel coronavirus. So you do not need to worry about it. If you are worried, if they do fill the epidemiological criteria, we would not expect that test to be positive on our viral throat swab here.
Okay, so I get the interactive session with our lovely model Neil Stevenson, who's the other ID Reg. If you guys want to make your way over there, Catherine's going to help as well. So obviously we're infectious diseases doctors, so we have to have a picture of the plague doctor. I didn't know Nick had one, so it's a bit awkward. We're going to go through PPE. We're going to use an interactive case using Neil as our example doctor. And we're going to discuss or present a variety of PPE, some appropriate, some not appropriate. We'll test your knowledge initially, so you feel free to dress them up in whatever you want. We'll then remove that and dress them properly and show you how to do it. So I realise, Perth, you're not going to see him get dressed up. Well, you might. Yes. But don't worry, because I'm filling all the PPE guidelines will come up in the slides to come. Okay. So the scenario, Neil has been told he's going to see a patient by Catherine and I. The patient was returned from mainland China 4 days ago and they have a cough and a fever. We, and I say we as the audience, are going to decide what PPE Dr. Stevenson will put on. I will go through all the PPE and then we'll ask for your suggestions. Okay, so we've got an FFP3 respirator Alpha 3000 series that Catherine is holding up. We've got an FFP3 respirator Alpha S series, an FFP3 respirator Alpha Mesh series. We've got a pair of Crocs. These are yellow, but there's no preference of colour. We've got a fluid repellent surgical face mask. We've got shoe covers. We were going to bring welly boots, but they were size 3 and they do not fit Neil. We've got a Doctor Who scarf. This is a fourth Doctor Who scarf, but again, there is no preference on this. We've got a plastic apron. This is your standard pinny. I've also missed out the picture of the fluid repellent surgical gown, but we've got this as well, so that is an option. We've got a full face visor with us today. We've got a bear hat, although there is a suggestion this might be a monkey. We're not entirely sure. We have some sterile gloves, and we have some non-sterile gloves, just your standard gloves. We've got a surgical hat, and finally, everyone's favourite, we've got the hood. I'm really sorry, we don't actually have a picture of the hood, so I had to cobble together a makeshift picture of the hood. But we have it here with us. Okay, so Neil is ready when you are. So who wants to shout out the first option that they want to put Neil in? He's about to go and see the patient. Scarf is on. So this is a fourth generation's completely impractical, but he could perhaps pretend he's got a TARDIS, travel back to time where coronavirus did not exist. Anyone else? Options?
Has he been face fitted?
That's a very good question. Neil, have you been face fitted? Yes, you have been face fitted. And what mask were you face fitted for? He's picking up the Alpha S series. Excellent. Are we going to put that on, or are you just asking if he's been face fitted? Put it on. Put the mask down, put the monkey on. Right. So on. A friendly face for the patient. Right. Anything else? Now put the hood on. The hood. I was a bit worried how this was going to go, but I sort of knew deep down how it was going to happen. Catherine is here to assist. The hood is less than ideal. You can secure it from the inside, and we have the fan that's buckled round his waist. We're going to turn it on. I think we should put it to full speed. Battery's a bit low. We can hit it again to go into full speed. Hit the button again, Neil. There we go. Anything else? You can be happy if this is what you want. This is fine. So we're going to put shoe covers onto hands. I can feel the infection prevention and control team might be slightly concerned by this. Don't worry, we are going to do it properly in a minute, so don't panic. Okay, are we happy? Anything else? Crocs on top of the hands, on top of the shoe covers. I feel this is descending into madness. Nick, I apologise. Right, I think we're happy. Is everyone happy? Good, right. Well done. Obviously that was a bit silly, but it highlights the variety of PPE that we've got, not including the scarf and the hat though. As Neil's taking that off, I will take this point to mention FFP3 face fitting. It is important that you get face fitted. If you haven't been face fitted in a while, go and find out who does your face fitting in your local area and get it updated. So we need people face fitted. If you have beards, it's not essential. If you have beards, you cannot be face fitted for the FFP3 masks. We do not like the hood. It's a difficult thing to clean. It's not ideal. Our first preference will always be an FFP mask. If you have a beard, your option is to shave it or get someone else to go in and see the patient, basically. Right, now we're going to do it properly. And what we're going to do is we're going to ask Neil to remove his lanyard. We're going to get him to roll up his sleeves because he's NHS Tayside. He should be bare below the elbows. This is an embarrassment. We're going to ask him to take off his watch. And we're going to ask him to remove his phone from his pocket as well, so he can stop Snapchatting. Okay, so we're going to put on a gown, and we're going to use the fluid repellent surgical gown. Don't worry about putting it on in a non-sterile way unless you're going on into the room to do a sterile procedure. He's getting some assistance from Catherine, sorry. And next he's going to put on the FFP3 respirator that he's been face fitted for. So thankfully we already asked what he's face fitted for and we have it in stock. So it's the Alpha S1 for Neil. But obviously you have to be face fitted to find out which mask that you can use. As he's putting that on, he's going to secure it in place and move his face and head around to make sure that he can't feel any leaks and make sure he's happy with it. Happy? Good. Next, we're going to put in a full-face visor. This is what we've got, and this is what we've stocked in the ward, but goggles will do. We need to cover your eyes. Normal glasses will not do, so we do want either a full-face visor or goggles. Next, we're just going to put on a pair of non-sterile disposable gloves. And he's going to put these on to cover up, go over the cuffs of the gown. So it's important to know where he's doing this. So if this is in a Ward 42 negative pressure room, he's doing this in the ante-room of that room. So he's not doing that. He's just broken a glove. Oh, typical. These gloves are amazing. You can put them on really easily when no one's watching. As soon as someone's watching, you look like an actual imposter. So he's going to do this in the ante-room of the negative pressure room. He's not doing this in the same room as the patient. So every high-risk room that we've identified, and we will go through this, there should be a designated area that's been assigned for putting the PPE on and taking the PPE off. Okay, so Neil has his gown, he has his FFP3, he has a visor, he has some disposable gloves on. Catherine has acted as a buddy system. He has ensured that he's got the correct thing. She'll have a quick look to make sure she's happy as well. If you've got that, it helps. Okay, he's now ready to go into the room. He's going to take the swabs, and now he's going to come out of the room. The Dobby's bag is acting as an orange clinical waste bag, sorry. And now we're going to take the PPE. So we're going to take the gloves off first, and this should be the appropriate way that we take off gloves. We're going to take off the gown, and we're going to be careful not to touch the front of the gown. So you can either rip it from top, but we're going to untie it first. And he's putting this into the orange waste. He's now going to take off his full-face visor or safety goggles. And then he's going to take off his FFP3 respirator mask. Now he's going to perform hand hygiene. Thank you. And now he's free to leave. It's important to know that the waste for these patients, and I'll go over it, is category B waste. We're expecting it to stay in the ante-room where the patient is, and it should be treated differently. And that is on the guidelines that will be on StaffNet as well. And Neil's free to do whatever he wants. Thank you very much, Neil. So the PPE is outlined in a document. We've tried to make it as simple as possible. It's also mentioning about essential staff should only be entering the room, avoiding the use of bank or agency staff if you can, and utilising the staff logbook is important. We need to know who's had contact with that patient. We've got order of PPE on, order of PPE off, and dealing with waste. This will be updated. It has already been updated in terms of the category for the waste, but keep an eye for it. It'll be on StaffNet. I'll show you where soon. The next thing I was briefly going to talk about is the preferred place of care for these patients, and then transfer routes that we've tried to identify throughout the hospital. Again, this is an evolving situation, and it will change depending on the testing of these rooms and the appropriateness of it. So ideally, as Catherine said, if they are well, we want them at home. We do not want them in the hospital. If they do need to come in hospital, the preferred place of care will be Ward 42 in a negative pressure room, not AMU. We want them in 42 in a negative pressure room. If they're unwell and needing higher level support, then ICU have been identified as the preferred place of care from that situation. And then we've identified at the moment room 1 and Ward 29, but that might change depending on the testing of those rooms. If the preferred place of care is unavailable, as in the beds are in 42 are completely full and we've got no movement, we have identified high-risk rooms in other areas of the hospital where patients may be arriving, particularly maternity area. So we have side room 10 in Ward 38 North, and at the moment tulip room in labour suite, but that might change. We've identified waiting areas if there's a turnaround. So they shouldn't be admitted to AMU, but if you're in AMU taking a history and you're worried that this might be someone at risk, as Catherine said, the first thing you're going to do is put a fluid repellent surgical mask on the patient, get yourself in full PPE, and ideally get them to a preferred place of care, which will be Ward 42. If we have a patient in that room and we have to make some movement, but it's going to be short turnaround, we've identified waiting areas. So for AMU, it's the ambulatory assessment area, just the examination rooms. You're going to put the patient in there. and get the patient transferred as soon as possible. Obviously, if the patient's been in a waiting room, you're not going to let anyone else in that room until it's been decontaminated. We've also identified the consulting room 3 in the early pregnancy assessment area as a waiting area only. So transferring patients, so the first most important thing is once you've got your PPE on and you're happy with the patient, you're going to find out where the best place for them to go, and you're going to contact the destination team prior to transfer so you can organise an appropriate time and confirm your route and entrances to that place. We want them walking if able and using the stairs instead of lifts. Plan the direct route with minimised interruptions and no stops, and minimise the staff for transfer. So if it's someone that's walking and that you can walk with them, one person is absolutely fine. We have a team have agreed about appropriate PPE for transfer. We think it's easier just to stick with know one set of PPE and stick with it. For the patient, you're going to use a fluid repellent surgical mask, and whoever's escorting them or has contact with the patient is going to wear the PPE as we discussed. So a couple of examples from some transfer routes. So again, this is outlining quite a large document, depends where the patient are and where they're going. This is an example of transferring a patient from resus room 1 in the ED to ward 42. So we've got options, ideally, if they're able to walk and weather permitting, if there's not a hurricane, to walk outside of the A&E with a member of ED staff escorting them in PPE, turning left towards East Block and using the stair behind East Block reception. Obviously, before they would have left, they would have contacted 42. Someone from 42 would be in full PPE, waiting, expecting to meet them. If they're unable to walk, then we've coordinated certain routes in the hospital that minimise going through high-risk areas or going through areas of other patients. Once the transferring staff have arrived at their destination, they will remove their PPE in the ante-room of wherever they've arrived, okay, so that everyone stays in PPE until they arrive in the place and then they're taking PPE off. This is just a note from AMU. We do not want the patients in AMU. We know this wouldn't be the best environment for them in terms of infection prevention and control. Some are going to slip through the net, so it's important to know your history and when you're taking referrals to know what to ask. But if they are there, basically we want them out of there and we want a surgical mask on them and getting them to 42 as soon as possible. Just a note for ICU, we're not using the main door for ICU, so obviously you're going to talk to them before you arrive at ICU, but we're going to be using the fire exit door. This means this is next to the PCI entrance door, and it means a direct route into the basically the side room of ICU. So this prevents you having to take the patient all the way through the middle of ICU. Paediatrics at the moment, because of the building works going on, there's a really convoluted route, an internal route to get to paediatrics, which makes it quite difficult and puts a lot of risk for infection prevention and control. So at the moment we have an agreed outside door, the Princess Alexandra route, and staff from 29 will meet them there. If there's a hurricane outside, we might have to revise how we do this, but at the moment that's the best route that we could devise that minimises risk of transmission. Just a note from maternity, we do not want, if you're pregnant but you don't have an immediate obstetric issue, we still want you in 42. So you're only going to be staying in maternity if you are delivering something. Otherwise we want you in 42. If your main issue is a concern about a respiratory illness that's possibly Wuhan novel coronavirus, we want you in the right area, whether you're pregnant or not. And we've identified areas. Unfortunately, we only really have one route for maternity. It's basically across level 5 corridor. So these guidelines, as Catherine said, will be updated. We have some on the AMU website already. So if you go to our websites, go to acute medical unit, you'll find a lot of the pathways and protocols there, everything that we've discussed. We will update them as guidelines change, as things evolve. And we're hoping to collate this into a high consequence infectious diseases pathway, not just for this, but for MERS, VHF, anything you can think of, and keeping things as fairly straightforward and as simple as possible. And that's us.
Thanks very much to the team. I'd just like to remind Neil that the YouTube channel that this will go on now has 10,000 subscribers across 50 different countries. It doesn't, but maybe it will now. You can watch this on YouTube as along with every other Grand Round that's happened since 2014, so if you're at a loose end. you're isolated because you might have Wuhan virus, then you can watch YouTube. I'd like to just highlight how much work has gone into all this. 2 weeks ago, we had nothing at all. And we had a call to AMU about a member of the public who might have come from that region of China. And we didn't know anything. We just knew that she was over here and had a cough. And within, 5 minutes of getting a phone call, we had the right people in the right place and stuff happened. Now we've got all this, so it's an amazing bit of work. And I think we should acknowledge that Ali and Catherine have done a huge chunk of this. So our registrars are really driving this forward, so well done. We have 1 minute. I don't think we've got time for questions. I suspect they'll be hanging around. If you do have questions about your own clinical area, you want to come and talk to people, then just come down right now. And otherwise, obviously, get off to your clinics, etc. Next week, it's my cycling videos, all my photos and slides from my cycling holidays from 2013 onwards. I'm going to talk about vaping, and I'm going to talk about smoking cessation. So it's an important topic, and it's going to be tied into our new smoking cessation policy for NHS Tayside. And Boosie wants to say...
PRI, we're working on your...
PRI, we're working on your route. But you've gone. Okay. Right, thanks very much, everyone. See you next week.